My name is Ijama Enuku. My topic today is on assessing nurses' attitude and knowledge regarding opioids. School is Northern Kentucky University. I'm doing my DNP. Teachers are Dr. Cooper and Dr. Candiliosa. Scholarly project proposal. As you can see, the background is mostly about pain management, how nurses came about being the first people that come in contact with patient and pain. It is amazing the work that nurses do to take care of our patients in pain. The main purpose of this is just to assess nurses' knowledge and attitude regarding opioid use and to provide education towards caring for patient in pain. This in turn will improve quality of patient care and maintaining patient safety. So the facts about opioid abuse or overdose in our country is alarming. Lots of patients are dying over pain and drug overdose. Educating our patients and ensuring safety is our number one goal. So nurses are held accountable to educate patients and provide high quality of care regardless. And to do that, we have to also take into consideration using the prescription drug monitoring, it's called PMP, getting urine drop, and educating patients on the need to stay compliant with opioids just for their safety. We're going to be using good validated tools. One of them that I chose is the one numbered from 0 to 10. 0 meaning no pain, 10 meaning high pain. That a patient tells you their pain level is 8 doesn't mean that they're not in pain or their pain is so high. You have to medicate her with everything on chart. That a patient tells you also that the pain level is 2 doesn't mean that the patient has no pain and you don't give the patient medication. So you have to look at several factors when you're taking care of patient in pain. You have to look at their culture, you have to look at their background, you have to look at where they're coming from, their tolerance to pain, all that you could do by assessing and getting strong history from the patient, detailed history. Try, as a nurse, try to ask them an open-ended question, meaning they have to explain more. But at the same time, keeping in mind that someone in pain doesn't have time for you to keep rambling. So you have to be able to ask one question that will give you all the answers you want. Start as simple as taking vital signs. Vital sign is not a reliable tool. It's not the only reliable tool to make you tell the doctor that this patient is in a severe pain. So that answer is false. The blood pressure being so high is not the only tool, or the patient, there are so many things that we have to look at when we're reviewing patients in pain. Also, recommendation summary. Try to evaluate this patient in detail. Try to find out how this patient got to this place. Try to explain what you're doing to this patient. Go and get the PMP. PMP helps in so many ways. It helps to prevent people shopping from doctors to doctors, pharmacists to pharmacists, providers to providers. It helps us cut that down. So patients are aware that you went to Dr. Jones last week and you went to Dr. Peterson the week before and things like that. So monitoring is good. Also having the patient sign a pain contract is also important. Collecting the urine to see if the opioid is in the patient's urine or what this patient has been taking also will help maintain safety and prevent possible death. So when we're trying to mitigate opioid, I'm gonna give you some scenario. This is where this project comes to be very interesting. I have a lot of interesting stories, interesting, and lovely. So bear with me and follow along. So when depending on the result of your findings, that's how you figure out when you're going to start tapering off these patients on their pain medication. So the question now arises, how long should a patient be on opioids? Should we give it for 1 month? Should we give it for 2 months? Or how long can this patient be taking opioids? And no one has found an exact time limit. So as a result, we're faced with the crisis of opioid overuse and opioid addiction and possible death. We're faced with that. Our leaders, our stakeholders, President Trump, everybody is working day and night trying to figure out how to stop this epidemic, how to stop this crisis from going on. So the best thing is to cut back on the frequency of prescription. A patient comes in for pain. You ask how often is your pain and everything. You give them 90. That is a lot for pain management for someone that came in for tooth extraction. Maybe we could start with giving Tylenol over the counter. Take 2 tablets every 6 hours and see how you feel. If the pain continues, come back. When the patient comes back, you reevaluate and you say, okay, your pain is a lot. I will give you 10 tablets of opioids for your pain management. And that's it. When you give them that pain medication, try to be firm. It's not candy. It's not something that we should not take lightly. It's something that we have to be held accountable. So you tell them this is the protocol. Have them sign a contract and tell them on their next visit you will evaluate. And the chances of not getting that high dose is high. So that's how communication plays a huge part. So our objective here is we're going to use a tool called the KASRP. This is knowledge and attitudes survey regarding pain. This tool has been known to be very helpful in teaching nurses how to manage their patients. It helps to assess what this nurse knows and also improve their knowledge. So please pay careful attention as we move along. Work with your doctors in terms of preventing opioid misuse. I know it is a very difficult position for doctors, providers to be in. Every patient that comes in will give out script so we could have time to see the next patient. So in the process, you might have created 20 addicts. But if we could take 2 minutes, if we could please provide 2 minutes to do a detailed assessment on these patients. Sometimes these patients will tell you that they're in pain, but their pain might be psych. Then we refer them to a psychiatric doctor. They might say they have abdominal pain, they're female, having female issues. We refer them to OBGYN. They might fall and break a bone. We refer them to ortho. So with one patient, you can actually have 6 different referrals. With one patient, you can create a lot of hope for that patient and the family. So please let's not judge patients when they walk through the door thinking that they're addicts or that they're here just to get by for their next fix. No, we have to look at patient as a whole. We have to be respectful. We have to be honest with these patients and honestly tell them that opiates will not help heal your pain. We need to find out the root of this pain and deal with it. And so, intervention. We first by assessing vital sign. The first thing you do when you're doing vital sign, you're looking at this patient as they're breathing. What are you doing? You're checking their eyes, you're checking their pupils, you're checking their respiration. That is the main key. If their respiration is less than 10, do you give opiates? If their respiration is less than 8, do you give opiates? These are detailed questions that we need to ask. These are clinical questions that we need to ask. So, vital signs are not the only reliable key for not giving opioids. You have to check other things. So, that answer will be false. You have to check everything. Please remember to use the scale, the pain scale when you're recording scale, proper documentation, put down the time that medication was given and the time to go back and re-evaluate the patient in 2 hours, put it down. When you're giving, report to the incoming nurse or outgoing nurse. Same thing as doctors. Please remember to put pain as one of the interventions you did on that shift, whether the patient was in pain or not. Remember to put down the location, what you did and what you didn't do, or what you intend to do. So, types of pain medication. Pain medication could be Tylenol, morphine. There are different kinds of pain medication. Some people use anticonvulsant medications for pain. Remember that when you give one dose of that gabapentin, it's not enough to take out the pain. When someone has shingles and they're in pain, it is not enough to give one dose of that medication to control the pain for anticonvulsants. So, causes of pain, there are several causes of pain. It could be diabetic, it could be osteoarthritis, it could be, you know, just getting old. And there's nothing wrong with getting old. and that you're getting old is not the sign of pain. Pain is not sign of getting old. That you're in pain and you're an elderly doesn't also mean that we cannot treat you for the pain. That you're in pain doesn't mean that we cannot treat you for the pain. So we have to be careful how we evaluate people and judge our elderlies when they're in pain. So we have a scenario here. This is a patient that was diagnosed with bilateral osteoarthritis 15 years ago, and patient has been on opioid for the past 3 to 4 years. However, she rides a bicycle 2 to 3 times a week, but there's no documentation on UDT. So, is there no documentation on UDT because the nurse didn't know to do it? Or is there no documentation because the nurse did not want to do it? Or because the clinic cannot afford to do it? Or shortage of staff, that's why it wasn't done? Or is there no documentation because the patient cannot pee? So documenting correctly helps. So towards the end of that month, the day, you could sit down and say, okay, we don't have cups. This is how we're going to do it. We don't have this. This is how we're going to do it. So in this case, this patient is on a lot of medication. So this is when the doctor will start looking into, okay, you're in a lot of medication. Let's see, can we get an x-ray of both knees to see what is going on? Can we refer this patient to a rheumatoid arthritis doctor to see if there's something they can do for the patient? Can we do, um, some other medication treatment to help this patient? So when we look at it, it is just that we need to check. Knowledge check here will be, you know, to try by doing urine dip, to try by doing PMP, to try by educating patient. When a patient tells you they ride their bike, is it the leisure riding bike or is it the exercise and riding bike? Actually staying on the bike and riding for 30 minutes and increasing your heart rate. Those are the specific detailed questions you have to ask patients. Then the second scenario is something similar, is all talking about pain. Lower back pain has been on med for 8 years and has also had physical therapy. Again, with physical therapy is not what you have one time. It is something that you have to be having on a continuous basis. As long as your pain is there, physical therapy should be there. And physical therapists are good in giving you homework to do at home. Simple, small exercises that will not hurt you, but will help you become more independent of your care. So you can walk, you can bike, laying down in bed, you can be biking if you can. They'll show you simple exercises to do. While you're watching TV, you could stand up and lift your arm up. Stretch, stretch. You could stand up and lift your arm. You could move around. You could get up from your chair if you can and go to the next couple of chairs. So we need to evaluate this patient. The cause of her pain is a vehicle crash. Has she been through counseling for the motor vehicle crash? Has she been through other form of referrals to help her understand the medication, to help her understand her treatment plan? Those that we have to look into. So, other ways that people could get also addicted to pain medication is going through the dentist, and the dentist will pull your tooth. So, it's very important to try to be careful with how you receive pain medicine. Learn to take Tylenol and take other non opioid treatment regimens that are offered to you. In that way, you could prevent getting addicted. So we also will talk about the vital signs once more. We talked about vital sign is not always a re- reliable indicator for pain. So the answer is false. Yes, children, because someone is a child doesn't mean that they don't have the same amount of high level of pain like an adult. So that answer is false. Children do have pain, and they're because they're under two doesn't mean that their pain is decreased, or pain is not less because they have little bodies. So then distraction. When someone is in pain, kindly plan on how to medicate that patient and make them comfortable. Don't start your distraction or telling her stories or judging them. Kindly give them pain medicine. Then, duration of morphine IV. Because morphine IV is like the number one medication in the hospital, all the nurses give it, all the registered nurses give it. So the duration is about 30 minutes to 60 minutes. So the Phenergan and Visceral are not reliable for opioid use. Please, when a patient is in pain, when you're giving Visceral and Phenergan for pain control, it is not fair to that patient because that patient will wake up and might actually be very upset. So, um, substance abuse, because someone has a substance abuse problem from opioid doesn't mean that you cannot give them opioid for pain management. However, if someone has opioid abuse, when you give them opioid, that opioid will not work. So it is not right to give patient that has opioid addiction opioid for pain management. Rather, it's best to give them Motrin for pain management. Repeat, if someone has opioid as a substance abuse, please do not give them opioid for pain management. You can only give them opioid for pain management between them getting withdrawal. So, what it means is all addicts that wants opioid for pain management have to stop taking opioid. No, they have to stop taking Suboxone for 4 to 5 days before taking opioid. For example, Dr. Smith comes in and sees a patient. A patient has opioid addiction and the patient is in severe pain. and unconscious. However, she has a bracelet saying that she is on Suboxone. Immediately, do not give that opioid that you're trying to give that patient. If you give the patient opioid and they're on Suboxone, they're likely to aspirate and die, meaning they're going to keep throwing up. They will not be able to control the vomit. They're going to be shaken. They're going to go through all the withdrawal. They will aspirate and die in their own secretion. So the only way you could save them is by giving them Toradol if they're not allergic to it, or you give them Motrin 800 milligrams. This is very, very important. If you do still want to give them the opioids, then that patient has to be under withdrawal. That patient has to stop taking Suboxone for 4 to 5 days and go through withdrawal before the opioids will kick in and control the patient's pain. So the higher opioids you give to that patient, the more likelihood that the patient will go into a deep sleep and will die. I hope you understand that, and please feel free to ask me any question on substance abuse. Again, with elderly patient cannot tolerate pain, so please medicate them with pain. Do not look at an elderly person that, oh, they're always complaining of pain. Yes, they are in pain because as you get older, sometimes you have limited mobility due to so many contributing factors like arthritis, prone to fall, anything. Kindly take good care of my elderlies. Please do not tell patients to endure pain. No one should be told to endure pain. So that answer is also false. So the next thing is placebo. Patients do not like the word placebo. Placebo means using water or substitute substance to replace the real thing. Kindly give them medication according to their weight and height. Throw the placebo in the garbage. Do not use patient pain in level of, do not use pain to evaluate patient's pain. Kindly use the validation tool to figure out how much pain that patient is having. So the answer there is false. Anticonvulsive convulsant medication is not for pain management. It could work, but you have to try to give it for the purpose. It does not relieve pain on the first dose. It will control the pain, but it might take the edge off in some cases, but it will still not control the pain. So all that I've mentioned earlier are all false, false, false. So the truth is, we're coming to that, sleep. Yes, some people could sleep through their pain. It doesn't mean that they're not in pain. But maybe the nurse came in and the patient just slowly drifted off to sleep. When they wake up, kindly ask them, are you still in pain? I have your pain medicine. Give them their pain medicine. Respiration is another way to see that patients are, the decrease in their respiration. Will tell you one way that to monitor their pain level. Combining analgesic is also good and can relieve pain. It's true. Patients' spiritual belief may make them think of suffering. That's true. Initial dose should be adjusted according to patient response. Like some, I think mostly in the ICU pre-op area, they give pain as according to how patient is responding to it. If patient is in more pain, they know what to give. Less pain, they know what to give. So try to follow your hospital protocol on that. Um, Vicodin and Tylenol together will give you morphine. Please, that is true. Kindly use them with caution. Benzo is used to control anxiety. Benzo is used to control anxiety. It is not really for pain, but you could use it for muscle spasms. So, narcotic opioid addiction is defined as a chronic neurologic disorder or disease characterized by behavior that include one or more of the following: impaired control over drug use, compulsive use, and continued use despite harm and craving. So we need to check the knowledge and attitude of ongoing and recommended route for opioid administration. Some people like to give the medication oral. Some people put it on the skin, and some people give it IM. And for cancer patient, it's best to give oral. If the patient is prone to aspiration, vomiting, and what have you, it's best to give it IM or rectally so the patient will not aspirate. Recommend to give IM if a patient has sudden severe pain, such as trauma or just coming out of the operating room. The medication of choice that doctors use in the hospital is morphine. So if somebody is to receive morphine over 4 hours, that would be equivalent to 30 milligrams of oral morphine given every 4 hours. The answer would be to give morphine 10 milligrams IV. So analgesics for patients that came out of the hospital should be given round the clock. So if a patient just comes out of the operating room, please don't wait for that patient to tell you that they're in pain. Just medicate them round the clock, follow the hospital protocol. Then when the patient is able to start telling you, I'm in pain, give it. I know a hospital, they'll ask the patient, are you in pain? Blink your eyes and I'll give you medication. It's not really right because a patient was not able to know where they were. She just kept blinking because she's trying to get out of the fact that she just went through the surgery. So every 4 hours, they were pumping her with morphine sulfate till she was able to lift her arm to say stop. She just lifted her arm and did this to the nurse, and they stopped pushing the IV. So we have to be careful with how we're asking the question. Then a patient with a cancer that was receiving analgesic for 2 months, but yesterday received 200 milligrams per hour IV. Today has been given 250 milligrams per hour IV. What are the likelihood that this patient will have respiratory depression? Is less than 1% because of the side effect of the morphine is to depress respiration. Most likely, patients experiencing increased pain, we have to increase the medication, right? The patient keeps telling you, I'm experiencing high pain. Try to increase their pain medicine and evaluate which of the following are useful treatment for patient in cancer. So the patient that has cancer, we give Dilaudid, we give Motrin, we give Neurontin. So all of the above is what we give them. So the patient also that the the most accurate judge of intensity of pain will be from where? From the patient. So this patient culture is very important. It's very important that we judge and we look at individual patients' culture. See, Hispanics express their pain differently from Americans. The Hispanics have high pain thresholds, and they're not known to tell you that they're in pain. They'll just keep on, enduring it. So you have to be extremely careful of how you are assessing their pain. So how likely is it that patient who develop pain already have an alcohol or drug abuse problem? Is a 5 to 15% is less likely. The time peak for morphine given is 15 minutes, and the time peak effect of morphine given orally is 1 to 2 hours. So given IV is 15. You see how fast that goes? 15 minutes, the patient is home. By IV, in 1 to 2 hours, the patient will get it. So the side effects that we have to see and discontinue giving opioids. Patient is sweating, yawning, having diarrhea. Patient becomes agitated. Also, if patient has loss of consciousness, just look at it as if the patient has any um, different symptoms from normal. You have to know the patient's normal from abnormal. So you write them down, then you have to assess accordingly. Maybe is this patient going through withdrawal? Is this patient going through? You have to know the side effects. You have to know the side effects. Okay. So here is another scenario. Andrew, 25 years old, came in for the first day from abdominal surgery, but patient vital signs are stable. Patient tells you that the pain is level 8. So when you get the scale, you have to circle 8. Whatever the patient tells you, you have to circle it. So then the patient, when you're doing your assessment, you come back and the patient says the pain from 1 to 10 is a 2. The question is, do you give the patient medication? The answer is no. You do not give any medication at that time. So if that patient comes in, if you come into that patient's room and the patient tells you, oh, my pain is still 9, for example, first, what do you do? Of course, you ask where the patient is having the pain. If the patient points the stomach, make sure that you relate that to the doctor. Why is this patient still having severe pain of 9 to 10 after post-op? What is the norm? So that's when the doctor might order another ultrasound of the abdomen or something to check what is going on in there. So let's try to use critical thinking when we're medicating our patient. Let's fight this fight the battle of opioid epidemic. Let's stick together as one and join hands to fight this battle. Our children are strongly affected in a neighborhood where one child is addicted to drug. It means that all the children there are addicted to drugs because all it takes is one apple and the whole apple will be spoiled. So if you see someone using, do not judge them, help them. There are centers available. President Trump brought out some money to help families that are going through this disease. And nurses should be empowered to help guide patients towards the right direction in getting treatment. Do not be left alone. It's only a phone call away. Again, my name is Ijama Enuku, student DMP from Northern Kentucky University. Thank you so much for listening to my presentation.